unfortunately, we are not living in an ideal world. We are far from it. And what's going to happen is if everyone, if the government makes a recommendation or CDC comes out and I think CDC is thinking about saying everybody should be wearing a regular mask. Even with that, I think the whole supply demand is going to get majorly mismatched. What may end up happening is these are tough commodities to come by, even right now, even for healthcare workers. And they're going to be even more tough for us to acquire those masks, especially the N95 masks. So I think as important and as intuitive it is that everybody wears a mask, we have to look at the data, and we have to rely on data. That's something which we haven't done successfully as a country. So I think we need to start relying on it, see what that's going to lead to. If general public start using this mask, it's going to be a huge shortage.
And thanks for that. Now, getting to your specialty, we have seen that people that have underlying health issues have been at risk of having more severe symptoms or reactions to COVID-19. So how does the virus kind of impact people that have heart conditions?
Majorly, so we always say that COVID-19 unfortunately impacts those who happen to have underlying comorbidities a lot more. So what are these underlying comorbidities? It's actually cardiac disease, people who have hypertension, people who have diabetes and already had blockages in the heart arteries before what we call coronary artery disease, people who have congestive heart failure, along with cancer patients, patients on chemotherapy, along with patients with asthma, bronchitis. These are the sick people in our society. These are patients who are walking in and out through my office. These are the folks who are unfortunately most vulnerable to COVID-19 in terms of getting the infection. Not only that, these are the same folks, when they get the infection, they're going to fall into that unfortunate 3 to 5% of population who are going to unfortunately succumb to this disease and perish and may get sick and get into the intensive care unit. So we are seeing a lot. As a cardiologist, a lot of our patients, they're vulnerable, and I'm on phone with them, I'm on virtual health with them, telling them every day to really isolate themselves and try to avoid getting in touch. But the other aspect of things is the routine cardiac care is also suffering. Right now, we are used to. If somebody has blockages in the heart arteries, chances are they may not get life-saving procedures even. In medicine, there is always black and white, and there is a huge gray zone. Unfortunately, that gray zone has gone so much more, and people who are absolutely not dying, if there are any other condition, we are not even fixing them right now. We are not doing their testing in the office. We are not doing stress tests. We are not doing the routine ultrasound to see if they have any serious vascular issue or not. And we keep saying we'll do it when things get better, but we don't know when that's going to be. So frankly, we have patients who happen to have blocked arteries, and we are not able to fix them. So we are being impacted a lot. We are suffering, and our patients are suffering.
And we were seeing that. I saw reports coming out of the UK that they were trying to ration who gets chemotherapy and who doesn't with cancer patients. So do you think something like that could come into play here?
Yes, absolutely. I think rationing of care is something that's going to be a real conversation. It's already become a real conversation for cancer patients and chemotherapy. I think it's going to go into other aspects of medicine. We're going to very soon have to decide, as you heard from many other people in Italy, we saw that who gets the ventilator or not, who gets dialysis or not. Because you got to remember, it's not just that people need these procedures or this supportive care. There is a lot of personnel that goes with it that surrounds this care. We need to have the actual space, the beds, the machines, and the personnel. So this all will be affected. Same way cardiology and cardiac care is 100% being impacted. We are not doing cardiac catheter procedures. We are not doing some of the surgeries that we think could potentially wait. But again, it's cardiac disease. You really don't know how long some of those things can wait. I'm also a vascular specialist, and actually this happens to be a DVT, which is deep vein thrombosis or blood clot in the leg, DVT Awareness Month. And vascular care is majorly affected. We have people who have serious circulation problems, whose quality of life as well as their longevity, both are impacted. And we can't really go and do a whole lot about it because we don't know when it's safe to start reutilizing some of the resources, which are all currently directed towards taking care of COVID-19 patients.
So what would be your advice to these patients that might see their services cut? What do you say to them?
I think seek attention, get counseling, talk to your doctors. I think what we are doing in our practice is we are really individualizing, seeing people's risk, trying to, no one can predict the future, especially in advance, as they, but we are trying to do that. We're trying to see people, hey, I think you have these issues that really, but hopefully within 1 to 2 weeks, you should be fine. Let's readdress, let's reassess 2 weeks. So that's what we are doing. All terminology, we are punting the ball as much as we can and reassessing them. But my advice is, don't ignore it. And making COVID and COVID-19 is symptoms. So we are, who are coming into the heart with what sounds like heart disease. So your cardiac symptoms, shortness of breath, discomfort in the chest, in touch with your doctor's office. They're available on, so get that help. Figure out whether you bet is to stay away.
And just quickly, how are you? This is a question that we had.
So again, I want to clarify, is very specific. Emergency room, people are intubating, ER, front line. I am front